Okay, everybody, welcome back to part 4 of the cardiac emergencies lecture. We've already gone over the anatomy and physiology. We've gone over the electrophysiology of the heart. We've started diving into coronary artery diseases, and we've gone over angina versus AMIs. So now we're going to get into cardiogenic shock and a couple other disease processes here. Anytime we are suffering from any kind of cardiogenic shock, and I know that you guys have already had the shock lecture, so hopefully some of this will be a review for you guys. But cardiogenic shock usually is because of a pump problem, and it's some kind of impairment to the myocardium, whether it suffered a trauma, whether the actual heart muscle is not being perfused for whatever reason. The myocardium, the actual heart muscles, are not functioning the way that they should. The heart is no longer able to pump effectively. Because the heart is no longer pumping effectively, it could be either too fast or too slow. There is a decrease in cardiac output. And because there's a decrease in adequate cardiac output, this can also decrease the inadequate tissue perfusion all the way down to my big toe. And remember, the definition of shock is inadequate tissue perfusion. And again, with cardiogenic shock, this could be because of a heart attack. This could be because of a blood clot in the lungs. This could be because of a stroke, right? It can also be because there's a bullet that went through your heart. It could be because you weren't wearing your seatbelt when you were in a car accident and your chest bounced off the steering column and you actually bruised the heart, such as like a cardiac tamponade or something like that. So intrinsic and intrinsic causes for cardiogenic shock, and we'll get into it a little bit more in these next couple slides. So the more common intrinsic causes is the actual myocardial damage. We have suffered a severe heart attack, or maybe we have suffered numerous heart attacks over our lifetime, and our heart is just not beating effectively in order to help us with cardiac output. We could be in a dysrhythmia, whether our heart's beating too fast, whether our heart's beating too slow. It could be regular, it could be irregular, it could be regularly irregular. It could be all kinds of different stuff, but for whatever reason, we have a dysrhythmia in our hearts, and because of that, we are decreasing cardiac output. Or it could be a possible problem with one of our valves. You guys might hear terms of like aortic stenosis or something like that. It's the actual hardening of the valves. Remember that the valves only open one way, and sometimes we can have valvular disruptions where the actual valve doesn't close the way it's supposed to, and it's actually kind of held open. Usually this is, people can be born with these, and they're usually kind of fixed right after birth, or the doctors might be waiting to watch to see what actually happens during the lifetime of the patient and then perform the surgery when they need to. There's all kinds of different things that can go on with that. Or this can also be because there happens to be a heart attack in the blood vessel that provided blood flow to the valves, and now we have some kind of valvular disruption because we've actually killed off that part of the actual heart muscle. Extrinsic causes, remember, these are outside forces in, so this is usually dealing with some sort of trauma. A bullet hole through the heart can really throw off the heart rhythm. If cardiac tamponade, remember that's the bruising of the heart. We've already talked about this a little bit. You can actually bruise the heart tissue. You can hit your chest so hard that you actually bruise the heart tissue. That's going to act like a heart attack. It's going to mimic a heart attack. People are going to be complaining of similar symptoms as they would to that, like that OP cure STU for the myocardial infarction in my last lecture. Or this can also be due to a tension pneumothorax. The actual interthoracic pressure is too high due to a hole in one of the lungs, which is starting to push everything over towards one side of the chest because the air is not able to escape the actual thoracic cavity, and this can put pressure on the heart, almost kind of squeezing it, or actually basically becoming a tourniquet for the heart, and the heart's just going to keep beating faster and faster and faster. The faster the heart rate, usually the lower the cardiac output. The lower the cardiac output, the higher number of cells that are not getting perfused, and eventually that heart's going to get tired and it's going to stop. So the signs and symptoms of shock. Again, hopefully this is a review for you guys because you guys already watched my shock lectures. But again, guys, it really starts with the patient's mentation. Okay, they could be very restless, trying to find that position of comfort. They can't sit still. They might feel like they need to stand and walk around. Okay, they could be anxious. They could have like dullness. They're kind of dazing off, or they're not able to keep a thought, or what we call a very kind of loose cognition, where they're jumping from one subject to the next and they're really not answering questions appropriately. They could have rapid shallow breathing. They're going to have that weak radial pulse. Why is that? They have that weak radial pulse because something's going on in the core. The brain's getting upset, and it's going to start pulling all that blood. It's going to start shunting all that blood from your fingertips, because the brain's saying, hey, right now, I don't care if you have blood in my hands. I need the blood in my organs right now. So it's going to actually start shunting that blood away from your peripherals and into the core of the body. So that way, you could have a weak radial pulse, or that radial pulse may not even be present at all, depending on what stage or what process of shock we're actually in. Pale, cyanotic, cool, clammy skin. It is the only organ that we can see. It is the cover of the book. Do we want to read it or not? Okay, if our skin is pale, we are not perfusing accordingly. I'm going to say that again. If our skin is pale, we are not perfusing our cells appropriately. Okay? I think that's between the restless, anxiety, and mental dullness, and the pale, cyanotic, cool, clammy skin. Those are the first two signs and symptoms you guys should be screaming, hey, this patient's getting shocky in me. This patient's not perfusing well. Okay? We really need to start thinking about, hey, this could definitely be shock. Nausea or vomiting, okay, sure, that could definitely be a signs and symptoms of a shock. And then low blood pressure. Again, remember the difference between compensated and decompensated shock is a drop in blood pressure, the first drop in blood pressure. And it doesn't have to be significant, guys. It could be that patient where you had a blood pressure of 150 over 100, right? And they're pale and they're anxious and they're breathing really fast and they have that high heart rate, and all of a sudden you check their blood pressure again and it's 140 over 90. We have had a drop in blood pressure. This patient's starting to become shocky. It's time to start treating for shock, right? And I want you guys thinking about it in the back of your head. Remember your treatment for shock, because you're going to see it on a test. Make sure you guys know the treatment for shock at the basic level. Okay, moving into congestive heart failure. The heart has lost its inability to pump effectively, and this is usually due to probably a heart attack. It could be due to any kind of coronary artery disease. Remember, there's quite a bit in coronary artery disease. There's strokes, there's aneurysms, there's high blood pressure, there's angina, there's heart attacks. Okay, so remember that you guys, just remember that coronary artery disease is a broad generalization of 4 or 5 different actually disease pathologies. All right, it could be due to an infection. You can get an infection of the heart, and you guys can have infections of your body that can actually move to an infection of the heart. Really, when it comes down to it, the most common demographic of people that actually get infections of the heart are the IV drug abusers. People that share needles and shoot up with heroin or something like that, they can get a very serious infection of the heart known as pericarditis. And pericarditis can actually kind of mimic a heart attack, but it's actually a criteria that we look for in paramedic school, where we have what's called ST elevation in every single lead that we can see when we're doing an ECG. Again, you guys don't need to know that. That's a little bit above your pay grade at this point, but know that you guys will be able to see infection of the heart when you guys are looking at the ECG on patients where you might have somebody in congestive heart failure. Chronic hypertension, right? We have so much pressure in our system, and our heart needs to pump against that pressure every single time it pumps. Well, remember, the heart is a muscle, right? So if you are pumping against pressure, your heart rate or your muscle is starting to grow, and we can actually get an enlarged heart because of the blood pressure being so high with somebody. And when that chronic hypertension kind of kicks, that heart can actually get too big or actually can get too strong in order to be able to pump effectively. And then, of course, any kind of trauma could lead into a congestive heart failure as well. Okay, so the heart is a two-sided pump, right? We can have damage to the left side, which makes the left side not pump effectively. We can have damage to the right side, which makes the right side not pump effectively. Or we can have both sides not pumping effectively, okay? If we have damage to the left side, if we are suffering from left-sided congestive heart failure, okay, that means that there has been injury to the left side of the heart and damage to the left ventricle muscle, okay? Because of this, the left side has what's called a reduced stroke volume. The heart, the right side's pumping great. The left side's not pumping in sync with the actual right side of the heart, or it's not pumping or getting enough squeeze like that right side of the heart is, okay? So the problem with left-sided congestive heart failure, and let's think about this. My right side's pumping fine, right? And that right side pumps blood to the lungs, correct? But my left side isn't meeting up with the demand of my right side because my left side has been damaged and it's not pumping effectively. So because my left side is not pumping effectively, I can't get out all the fluid that the right side of the heart is throwing down my gullet, basically, right? The right side of the heart is still getting all that oxygen, getting all that deoxygenated blood into the lungs, right? The right side's still pumping faster, so it's pushing out that blood from the lungs and it's dropping into the left side of the heart, but the left side of the heart is not pumping effectively. So if I have somebody suffering from left-sided congestive heart failure, the blood is going to start backing up into the lungs. Just remember left and lungs, L and L. Left-sided congestive heart failure starts backing up to the lungs. We talked about this already a little bit in respiratory. We're going to get some nasty lung sounds, okay? We're going to start to engorge our capillaries with fluid. That fluid's going to start backing up in third spacing into our lung tissue. And we're going to have patients that are short of breath and chronically short of breath with left-sided congestive heart failure. This can happen very suddenly, just like a heart attack can. Or this can happen very slowly over time. Specifically, the example with that would be somebody with high blood pressure. So with that left side not pumping correctly, again, that fluid backs up into the lungs, and we start developing pulmonary edema, or just fluid in our lungs. This is going to start developing as a shortness of breath. We could get those fine or coarse crackles, right? That can also start leading to rales or bronchi. And we can, if it's really bad, we could start developing that pink frothy sputum, where we have engorged our capillaries so much that not only are we releasing plasma, but now we're starting to spill blood into our lungs, and we're actually starting to cough that up. The other thing, keyword with left-sided congestive heart failure, is something known as orthopnea. And orthopnea is what's known as positional shortness of breath. So these are the people that might have to sleep with pillows to kind of prop them up. They can't lay flat in the bed. They might have to sleep in their lazy boy, right? They can't lay flat, or if they do lay flat, they become more short of breath than if they were sitting in like a semi-Fowler's or a high Fowler's position. Okay, and opposite, when we're talking about right-sided congestive heart failure, the right side of the heart has been damaged from something, whether it's trauma, so it's an intrinsic or extrinsic cause. The right side of the heart isn't pumping effectively, but the left side's still pumping effectively. So the left releases the blood, the oxygenated blood goes all the way down to the big toe. If the right side is damaged, the blood's going to actually start backing up into the body. These are the people that you see that have severe swollen lower extremities. Okay, the right side of the volume has a reduced stroke volume. the left side is still working correctly, and if the fluid's going to start backing up to the body. The other thing I want you guys to keep in mind that if the left-sided congestive heart failure goes untreated, it can lead directly to a right-sided congestive heart failure. It is more common to have left-sided congestive heart failure than right-sided congestive heart failure. And I was told by a cardiologist one time that most right-sided congestive heart failures are due from left-sided congestive heart failures. But I haven't really found any research on that. So I'm going to take his word on it because he's a cardiologist, and I respect him as a cardiologist too, and as a doctor I think he's great. So I just want to kind of share that with you guys. But the fluid's going to back up into the body, right? So we have the inferior and superior vena cava kind of dumping blood into our right atrium, and it's not pumping effectively, so the stroke volume is depleted, which means the blood's going to back up into the body. Because that fluid is backing up in the body, we can get systemic fluid retention or fluid retention throughout our body. Usually it's seen in the swelling in the legs and ankles and the feet. We're going to talk about pitting edema, where people are so swollen in their lower extremities that you can actually push in their skin on their ankle, and you actually leave an indentation there. That's how much fluid is actually backed up into their body, okay? They can also have pain to the right upper quadrant, and specifically they're getting pain to their liver. And their liver, again, remember that the liver is used to help kind of filter out the blood, and it's getting backed up. It's becoming engorged, and the liver is actually starting to swell. And that's a very late sign of right-sided congestive heart failure. And again, it could be acute or chronic depending on what happened to the patient. But that is a very bad sign if we have swelling going all the way back to the liver. This patient does need to go to the hospital. They do need to be put on diuretics in order for them to actually start peeing out all of that fluid in order to kind of put their liver at rest and kind of take the demand off the right side of the heart. The other thing that you guys are going to see are distended external jugulars. Your external jugulars are on the sides of your neck, both the left and the right, and they're going to look like they're extremely bulged because of the actual fluid backup from the superior vena cava coming from the actual brain itself. Okay, so here's a great slide to help you guys study about the difference between right-sided and left-sided CHF. Again, I'm not going to read this to you. When you guys see that JVD, remember that's that jugular vein distension, or that extended external jugular veins. So you guys can look over this. You guys can use this to help study, and this will be on your next exam as well.